Now, you reminded me of a stewardess with your tour guide. This is your Christmas tour. And so I'm going to take it away from there and say that while we will not be flying at 30,000 feet, we will be talking about people who might be. So let's go ahead with substance use disorders and psychosis. It's an interesting topic for sure. There's a lot of information here, so I'm going to rip through it pretty fast, but be sure that you will get the PowerPoint. So first thing that I want to say is that there's an awful lot of substance use disorder within the psychosis population, and I know that I'm preaching to the choir. Y'all know that. Cannabis has the highest lifetime prevalence during first episode psychosis. And it tends to, remember the big discussion about, is cannabis a gateway to other drugs? It turns out that it might be a gateway to some drugs, but not necessarily all drugs. So cannabis use tends to predict stimulant abuse. And both of those things, cannabis and stimulants, dysregulate the whole dopamine system. My guess is if you've had people who have drug use and also a diagnosis of psychosis, they're probably using meth and cannabis, which are the most popular ones at this point. And, oh, there we go. So, and to be clear, definitely that those that we treat for psychosis are often left out of or excluded from trials that have to do with chemical dependency. And the same is true for chemical dependency. Any trials or research tends to exclude anyone with psychosis. So it ends up that neither population really gets the best treatment. So, but in fact, they're very connected in many ways. There's three different models that we could look at that was kind of highlighted in the research for me as I was researching this. And the first one is how does addiction come about? SelfMedication model, right? That we've kind of discussed that for decades. So if that were the truth, though, we would see a decline in troublesome behaviors with the onset of drug or alcohol use. And it's clear that we don't see that. We do see people using to increase their pleasure and to relax, and that might help to relieve some depression and anxiety. So we can certainly see that there's some help in the short term, but not in the long term because of all the consequences that develop. The other explanation for the provocation of an addiction is the stress vulnerability model, and you're all very familiar with that. This would indicate that drug use would precipitate psychosis, right? So we can't prove that pot, alcohol, amphetamines, or anything else, quote unquote, causes psychosis, but they produce many factors inside the body and environmentally that might bring that on. So there are clearly shared risk factors of both camps here. And just having it be the stress vulnerability model is a little bit simplistic, but it does have meaningful impact, right? We have a vulnerability to comorbid dependence and psychosis. So with an addictive person, somebody who has addiction and an addiction brain, so to speak, we've discovered that there may be a deficit in the reward system in the brain, right? So in the brain, there's a specific reward system. When neurohormones are released, that's the reward. It's kind of like on a very, very hot day and you drink a cold glass of water and it feels wonderful going down. That's a dopaminergic release right there. It's that kind of relief that happens. In schizophrenia, we also know that there's a deficit in the reward system, and it creates hypersensitivity to substance-related signals because those substances are in fact producing neurohormones that are going to provoke more problems. So because there's a deficit in the reward pathway, and that might be related to developmental abnormalities in the brain, the hippocampus, the frontal cortex. Hippocampus, remember, is where memories and learning takes place. So what folks do is they self-medicate to relieve their symptoms. And what happens then is that the dysfunctional reward system in the environment and the drugs in the system and the brain all work together to produce this dual diagnosis. So here we go. Here's kind of a large map of that: psychosocial factors, neurological factors, and that reward system work all together. So none of those models are necessarily mutually exclusive, okay? The cannabis issue is really complex, and that is because there's different amounts of THC and CBD in anything that somebody might buy over the counter, and certainly if they're getting it off the street, we have no idea what's going on in there. There may be other drugs that this person has used in combination with cannabis, or in addition to. Some folks smoke every day, all day long. Some folks smoke only situationally or socially, quote unquote. And heavy cannabis users, particularly when they're young, tend to end up with kind of a schizophrenia profile if they are vulnerable to that. If there's those brain abnormalities that kind of predispose them. Cannabis consumption during adolescence will disrupt the normal brain maturation, okay? And the end condition looks a lot like schizophrenia. Nobody has ever said it causes schizophrenia, and most researchers will definitely say that this happens with people who are vulnerable to this condition. So not every adolescent who uses cannabis is going to end up with psychosis. Clearly, there needs to be hereditary factors, whatever abnormalities there may be, so on and so forth. Now, one of the things that we really ought to think about when we're sitting down with a client with chemical dependency is, what is their motivation to use? A lot of times we'll sit down with somebody who are using, and you know, when I first started in addictions, my first thought was, oh my God, your lips are moving, you're lying, right? And just kind of treating them in that tough love, old AA way, which doesn't really work for a lot of people, it turns out. So what we need to do is to do the same thing that we do with people with psychosis, which is to sit down and listen to them, to engage them, to build a relationship with them, and to find out what it is that motivates them to use, right? So we can't really intervene appropriately in a therapeutic way unless we know what's underlying the disorder. So a lot of specific information can be elicited from the client regarding their motivation with Socratic dialogue, getting a history, doing a trauma history. And having that history may help you as a clinician help to keep this client from moving forward with that addiction, right? We know people who smoke cigarettes do so because they feel like that helps them in their everyday life kind of cope. And people begin to use cannabis for a sense of relaxation and pleasure, that euphoria that comes with that. Interesting, people who drink alcohol do it in order to enhance their social skills. Sad that it only works for a little while, and then it just kind of blows the whole social skills picture out the window when they start dancing on, you know, bars and putting lamp shades on their head. Voices are too loud for people with psychosis, and we've all heard that from our clients. And so some of that is to learn to distract from the voices or try to temper the volume. Other people will drink because use because they just know that they look odd to other people, and we can see that, we know that. And a lot of people just can't sleep with psychosis. At some point, we'll do a didactic on psychosis and sleep disorders, but there's probably a majority of people who have insomnia or other sleep disorders who also have a diagnosis of schizophrenia. So these are some very important things that we need to get down to the bottom of. Is it trauma? Is it voices? Is it symptoms? Is it, I need to relax and I can't catch a break, right? So formulation is really, really important. Okay, so doing the, oh, here's another one. I've been abducted by aliens, right? Some people are just terrified. Most people are just terrified, and using some cannabis tends to dampen that terror out for the short term. So sitting down with a making sense form is really super important with that. Oh my goodness, I was going crazy with this. Assessment issues. If there is a diagnosis of psychosis, you also need to do a chemical dependency assessment, right? That's just, it should be normal procedure to do that. Half the population with a diagnosis of psychosis also has a diagnosis of substance use disorder. So, and if you've got somebody with substance use disorder, there needs to be some kind of assessment for psychosis. Now that may be a shortened assessment, but it should prick up anybody's ears, right? That both things need to be assessed. Underreporting is really frequent and very common. And if somebody chooses to stop using, particularly if it's a heavier drug like meth, well, that withdrawal, alcohol, can look a lot like psychosis. Gosh, alcohol withdrawal is more likely to kill somebody or put somebody into a psychotic state than many other drugs that we come off of. So there aren't really many good assessments specifically for substance use disorders and psychosis. So assessment really has to be multidisciplinary. You've got to talk to other members of your team. It's important to remember too, that when we sit down and talk with somebody with substance use, we don't want to start out with, what are you using? How much are you using? Because what that does is it just brings up the euphoric recall that addicts have. Euphoric recall is thinking back to those times when you were stoned and it was really wonderful and the craving starts again. So don't ask about first use. Slowly move into the use history. And it might be important to talk about what consequences the person has experienced. Maybe they're sitting in your office because of a consequence of drug use. So the other thing that we need to think about is that people with psychosis tend to be super sensitive to drugs coming into their system. And just simply because of whatever brain abnormalities and deficits in the reward system there may be, are just super vulnerable to fall into an addictive pattern. The assessment tools that we can use are ones that probably all of you have in your agency. That the audit and the MAST are real common, as is the DAST. They've been around for years. They're very short. Some screening tests have been developed, or looks like there's still research coming in on these, but the Dartmouth Assessment of Lifestyle Instrument is good, and the Substance Use Event Survey is good. I doubt either one of those are free, but they are assessments that you could look up on Google and download or buy. Treatment is a really important issue as well. So we have tried many ways to treat comorbid substance use and mental disorders, psychosis. One is to do that separately. A lot of therapists will say you got to get them clean before therapy will work. And a lot of therapists say you got to do the therapy in order to get them clean. The thing is with psychosis, you have to do it together. It really, best practices is to have an integrated treatment process so that the same therapist who's working with the addiction is also the same person who's working with the psychosis, and coordinating all that information between the various teams working. So this means there needs to be low stress harm reduction techniques. So we're not going immediately for abstinence. It really needs to be motivation based so that their behavior ends up being value directed towards a goal that they hold precious to them. Use of CBTp is efficacious both in psychosis and with addictions, very much so. We also need to really help support functional recovery. We want to make it so this person feels comfortable going out into the world and doing everyday things. So we need to engage the client's social network. So if families need to be involved. Maybe if there's a good friend who's sober, building up some kind of a self-help group. And if there is no integrated treatment available, which I imagine is true for most of us here, there needs to be coordination among all providers who are willing to work together to do this for this population within an agency. And I know that that's a tall order. Specifics of working with psychosis with addiction is engagement, right? Same old stuff that we see with psychosis, finding common ground, having empathy, acceptance, and building a strong working alliance. And I know that that's really tough to do at times with somebody who's demonstrated, perhaps antisocial behavior within their use, or who has been very mean or a very frustrating client. Is very hard to do. And we need to remember that this all does, in part, go back to neurology, just like with psychosis, and it's kind of compounded. The one compounds the other. So stay with a START structure. That's really important. Structure is important for both populations, and collaboration is super important. If you don't have 80 or 90% agreement that they're going to follow through with homework or some kind of activity in session, they're not likely to do it. They'll come back and say, well, gosh, I forgot, in which case you do it right there and then. Socratic dialogue and guided discovery are very important as well, because this is going to lead you to what ultimately led them to the addiction path. And I have worked with people with comorbid psychosis and addiction. And for me, what I've seen is that addiction starts super early. Sometimes I had somebody who began using with their father in elementary school. And somebody who's been using that long is going to find it very, very hard to stay sober for any length of time. That young man was able to put at least a year together, and then he relapsed, and I hope he's back in recovery again. I think that he is. Working with symptoms, hallucinations, remember, it's very real to the person experiencing them. We can see that people hear voices through a functional MRI. The auditory cortex is on and ready to process internal acoustic information, right? And we also know that hallucinations are reflective of a person's life. And this, happens all within using, getting stoned, having consequences, and that vicious cycle of going right down the hole, right? So the goal is to reduce distress, not necessarily get rid of the symptoms, right? That's all very familiar. Delusions tend to not be quite as responsive to CBTp as hallucinations are, but we can still make progress with that. Some are able, I'm not actually going to go over all of this because you have a lot of information about delusions. Suffice to say that when we're using and having a delusion at the same time, again, things get very, very compounded. So along with all of this, again, we're looking for functional recovery. Can this person go out and manage themselves on their own or with minimal support? So again, it's mindset of the clinician working with this dual diagnosis person. It really does need to be structured. It needs to be formulation driven. It needs to be action oriented so that you are up and doing things in the session and recommending that they do things out of session, perhaps with a caseworker or other people in the community or with family. Certainly engagement and acceptance of symptoms. So acceptance kind of works very well with addiction, and acceptance of symptoms works kind of in the same way as it does with psychosis. I might have to accept that I have cravings for a drug, for example, or accept that I have certain cues in the environment that sets me up to use. Same kind of thing. And normalizing is helpful, and certainly cognitive and metacognitive skills training. So metacognitive skills training is particularly important for the addiction side so that they can see the spiral of destruction in their lives kind of from a helicopter view. That's a little bit harder with somebody with psychosis, but it's our end goal, right? So that's it. That's a lot of information, very brief. It was kind of an advertisement more than anything else. So there you go. And I'm